This podcast is brought to you by
Yeah,
Health.
yeah.
Hey guys, I know we all get tired. You're not alone. I get tired too. That's why I use kombucha.
Dr. Jay Shah is currently the Vice Chief of Staff of Stanford Healthcare, a staff surgeon and associate professor of urology at Stanford University, and the cancer care program leader for urologic oncology at the Stanford Cancer Center. Dr. Shah is widely respected for his work in optimizing outcomes after surgery for bladder cancer, and he lectures internationally on this topic. He's a graduate of the American Urological Association Leadership Academy, and he sits on multiple national AUA committees. With a deep interest in quality improvement work, Dr. Shah is the physician improvement leader for the Stanford Department of Urology and a medical director of the Stanford Realizing Improvement Through Empowerment program. Since joining the Stanford faculty in February 2017, Dr. Shah has successfully completed the Clinical Effectiveness Leadership Training Program, the Stanford Leadership Development Program, and the Stanford Medicine Leadership Academy. His vision is to have Stanford Medicine become known for instilling leadership in all of its faculty and trainees. With this goal in mind, he started an accredited fellowship training program in urologic oncology and a QI/leadership training program for urology residents. Dr. Shah also lectures internationally on leadership development, team building, and quality improvement. He graduated magna cum laude with a degree in biological sciences from Harvard College. He obtained his medical degree and completed his urology residency training at Columbia University. During his time at Columbia, Dr. Shah was elected to the Alpha Omega Alpha Medical Honor Society. He was named Physician of the Year by the nursing staff, and he was recognized by the medical students with the Gold Foundation Excellence in Teaching Award. After residency, he completed a 3-year fellowship in urologic oncology at MD Anderson Cancer Center, where he earned a coveted faculty position. During his time as faculty at MD Anderson, Dr. Shah launched the Bladder Cancer Robotics Program, developed an enhanced recovery program for patients undergoing bladder removal surgery, became double board certified in urology and medical quality, and was chosen to lead the MDACC Genitourinary Center as Center Medical Director. In his free time, Dr. Shah enjoys reading, cooking, surfing, hiking, and exploring the beaches of Northern California in his Jeep Wrangler with his family and 2 dogs. Jay, welcome to the show.
Thanks so much, Alan. Appreciate it. Happy to be here.
Amazing. So, Jay, you are a leader in urology enhanced recovery after surgery, or ERAS as it's commonly called. And you've led many quality improvement programs throughout your prolific career, both at MD Anderson and now at Stanford. I'm curious, just to start the discussion, where did that passion come from in terms of improving surgical quality?
Yeah, thanks, Alan. I didn't know when I finished medical school that that's where my career would go. I came to the realization that even after all the training that I had done when I was operating on my patients, because of the nature of surgery and how invasive it is, and the particular cancer I deal with, which is bladder cancer, a lot of these patients would do really poorly. So even though we were doing everything by the book, the complication rates for these patients was so high. And along with that came all this anxiety that the patient felt, because it's not easy to go through surgery, even when everything goes well. And then when there are complications afterwards, it just compounds the patient's anxiety so much. For a cancer patient to be thinking about having a large disfiguring operation in and of itself is stressful. And you add on the extra days in the hospital and all the extra uncertainty that comes with it. It made me realize that, hey, you know what? Maybe the goal is not just to follow the textbook to the letter, but maybe what we ought to be doing is figuring out, how can we do this better? There's got to be ways for us to keep tweaking this so that patients can do better, so more of the patients can have a smoother recovery.
And Jay, I remember learning how you did ERAS and urology at MD Anderson. You brought that to the program at Stanford. From talking to kind of your colleagues in the broader urology community, how common is ERAS now in urology? We keep hearing a lot for like colorectal and gynae and cardiac more recently, but like, what % of your colleagues do you think are actually doing ERAS right now across the board? And I guess why were you one of the first ones to do it, I guess?
ERAS it's kind of a blanket term. As we know, it's stands for Enhanced Recovery After Surgery. And it's not one thing. It's not that you turn a switch or you don't turn a switch on for these patients. It's a whole collection of things. It's basically a philosophy to managing these patients. So if you look at the folks around the country in urologic surgery who do the big operations, I think so many people would say, oh yeah, I do ERAS. I've adopted ERAS for my patients. But then if you break it down into, well, which components do you do? You'd see of the roughly 22 or so total components, a lot of people don't do, I'd say most people don't do all of them, and many people don't do more than just a couple of them. But in their minds, I think a lot of us say, oh yeah, I do ERAS, I use ERAS. We actually did a survey on this a couple of years back where one of my fellows, when I was at MD Anderson and we surveyed all the high volume bladder cancer surgeons around the country. And we asked exactly that question. Said, hey, what percentage of you use ERAS? And over 2/3, I think somewhere around 3/4 said, oh yeah, me, I use it. I'm on board with that. And then the follow-up question said, okay, do you do this? Do you do this? Do you do this? And we broke it down into not even all 22, but just 6 things and said, do these 6 very basic core components of ERAS. And the percentage of those same high volume surgeons that were doing all 6, mind you, it wasn't all 22, it was just all 6 of those components, fell to about 20%.
Wow.
Does it go back to that old adage of 80% think they're in the top 20% of anything? Or
Yeah, I think so. And I think, surgery has come a long way. I think a lot of us have realized that we can keep doing things better.
Mhm.
So we want to be, I think a lot of us want to be at the forefront. We want to be offering our patients these things that we keep hearing about are better. But it actually gets tricky once you try to implement ERAS at your own place. There's a lot of inertia that's in place. And I think, Alan, when you were reading my bio, you said one of the things that I'm deeply interested in is leadership development. And I think implementing ERAS actually turns out not to just to be a clinical care improvement initiative, but turns out to be an exercise in leadership, in your own leadership, trying to convince people, for the most part, people who are doing big urologic cancer operations have been doing it for 10, 15, 20 years. So for a younger surgeon to come into a department and say, hey, y'all are doing it wrong, let me show you how to do it. You can see how that's rife for trouble, where he or she is going to be labeled as an upstart or, these whippersnappers, et cetera.
I'm just curious, Jay. I mean, I'm sure a number of urology residents and fellows that have, trained, with you now have, learned a lot of these ERAS principles from you. Have you heard any stories of where, when they've gone off and, started working full-time in other organizations, that they brought this to those new organizations? Is that a common thing now?
Yeah. So almost everybody that's training in this day and age learns that for these big operations, this is something we should do. And, the idea of fast track recovery after surgery was first introduced back in 1989, 1990. And Josh, as you alluded, it was in the colorectal realm. But for the next 25 years, it was basically not really gaining much traction. But I'd say in the last 10 years or so, people have seen the results. Because things are so much more transparent, it's not only helped those of us that have already implemented ERAS, but for people who can't implement all the parts of it, at least can see that, all right, I should do this, I should do that, I should omit this, I should omit that. So I would say all the new trainees coming out feel pretty comfortable knowing what the ERAS components are and what we should be doing.
You've also, and sorry, Alan, I'm going to definitely go off script here, but,
okay.
but Jay, you've also been kind of a thought leader and an early adopter of things like prehabilitation. And I think the way we've come to think about it is prehab today is kind of maybe where ERAS was, I want to say 10 years ago, where you've heard about it, but probably most of your colleagues aren't doing prehab just yet. So it's not quite as prevalent as enhanced recovery. Where did you first learn about that? And kind of, are you seeing that more often in urology lately at all?
Yeah, so what you're referring to, in case there's a listener who doesn't know what prehab is, prehab refers to the idea of taking the window before surgery to get a patient as physically fit and optimized as possible. And I'm a big believer in the idea of prehab because we know that in general, if you take patients and just look at all comers, the ones who come in healthier tend to have a smoother recovery. And those who come in sicker and more deconditioned tend to have a tougher recovery. The question is can you take someone in that short 1 month, 2 month, maybe 3 month window, and can you change someone from being a sicker patient to a healthier patient so that they can have a smoother recovery? And I'm convinced, yes, that has to be the case. I think we haven't seen it adopted in any widespread manner because there's a lot of uncertainty about what exactly does a prehab program look like. There are people who have really great colleagues of mine who have tried to test it by saying, okay, here's a prehab program we're going to implement. We'll tell all these patients that this is what they should do. But then is telling a patient what they should do enough to ensure that they're going to do it. Now, we all know how bad we are about doing what we should do. And we all know we should work out 5 days a week, and all that stuff. But as young, healthy people, we have really good excuses. You can just imagine someone who's 70, 80, and has lots of other medical issues, other things competing for their energy and time. So we don't know yet what exactly is the specific sequence of things, motions, actions, activities that we should have a patient do to ensure that they're as fit as possible. There's, in addition to the normal difficulties of telling someone what to do, you can't just tell somebody, go to the gym, especially now during COVID, because gyms were obviously closed for a long time, but it gets difficult. One of the things that I've had my patients do, and I'm convinced that this is helping patients, is I just tell them at home to do a low plank. I just literally will, on a video visit, put up a picture of what a low plank looks like, tell them to put a pillow or a pad under their arms in case it hurts, but there's no impact. They don't need any equipment. There's no fall risk because they're 3 inches from the ground, if that. And I give them a crazy target. I tell patients, your goal is today, I just want you to do it for as long as you can. It may just be 30 seconds. It may be 40. You're going to think it sounds easy if you don't know what it is, but you're going to quickly realize you can't do it for very long. But every day from here on out, I want you to add 10 seconds. And I want you to get to a goal of 8 minutes straight.
Wow.
And if either of you have done a plank, that's a crazy goal. It's an insane goal. But I've actually had a couple of patients who have gotten there. Yeah. And every patient, even the 99% that don't get to the 8 minutes, go from 30 seconds, at least up to 2 minutes, 2.5 minutes, which is still a great plank, especially for someone in that age group.
Yeah.
And I think they feel a little fitter, and I think their core muscles are more sort of conditioned for the difficult, physiologic insult of surgery itself.
Yeah, that's a great way to put it. I want to shift a bit towards technology at this point, and maybe even with prehab and enhanced recovery, I can see how technology can actually maybe help with something like compliance, with patients actually understanding what to do. Maybe it's the plank and a reminder and things like that. But specifically, I know Stanford is notorious for being kind of this tech hub, as it's in the heart of Silicon Valley. And so I'm sure that you're pitched new technology all the time. And so, Jay, we were curious, could you share some of your guiding principles behind tech that you ultimately adopt for use with your workflows or your patients versus tech that you ignore?
Yeah, sure. Yeah, one of the things that drew me to the Bay Area was exactly what you just alluded to, was this embrace of the potential that technology holds for us. And I believe at the bottom of my heart that that's where the biggest advances for us and our patients is going to be. Unlike every other aspect of our lives, medicine has continued to operate in essentially the same ways that it did when our parents and grandparents went to the doctor. Back then, they walked into an office where someone greeted them behind a desk, handed them a clipboard, and they filled out a bunch of questions they filled out probably 50 times. And then someone took them to the back, put a little plastic cuff around their arm and took a blood pressure and one temperature and one pulse. And then a provider walks in and does their thing, and then they make a plan. That's exactly what we do right now. If you think about the way that we bank, the way that we travel, the way that we consume TV, or if it's still called TV, streaming services, the way we travel, fly, every other thing has come into the digital era. Medicine has remained behind. And I think it's easy to cast it as just antiquated, but I think it's also for good reason, in that the consequences of adopting the wrong things are just so much greater in medicine. We're reminded, unfortunately, all too often that we're dealing with life and death. So we've had to purposely be measured about what technology we should adopt and what we shouldn't adopt. The unfortunate end of that philosophy is that for those of us that want to keep pushing the envelope and want to try new things, it often feels way too slow. It often feels like my institution just puts up barriers. I don't want to keep fighting this battle. I have to do all these other things. So that was one of the things that drew me to Stanford, in that being literally smack in the middle of Silicon Valley and being at the place where all the big tech companies that we know of, had their roots. I was excited to be able to work honestly with people like you and some of the other folks that I collaborate with to try to figure out how do we do this responsibly. And for me, trying to decide for any particular bit of technology, is it worth it or not, is I don't know anything about market cap or price to earnings ratios or any of those. I don't know the business side of those things. It's just, what is my goal with the patients? And can this platform help me get closer to that goal? Is it something that both the providers and the patients can palpably say, okay, this is helping, this is making things better?
Yeah, that's a great perspective, because I think it's too often we get kind of drowned out by, like you said, like, what is the market cap of this company and how does this technology fit in the ecosystem of technology today? So I think that, focusing it back on, does this actually help the patient and does this help my workflow? That makes a lot of sense. And so, Jay, I'm really glad that you mentioned, you are a pioneer with digital patient engagement and this type of technology that SeamlessMD has. So Stanford was one of the first urology programs on SeamlessMD to use the technology to engage and monitor patients both before and after their procedures. And I think on the technology, you're using it currently for cystectomies and prostatectomies for those patients in that population. So I'm curious, what motivated you specifically towards a digital patient engagement platform for your patients?
Yeah, so you mentioned that we are using it for two of our patient populations in urologic oncology at Stanford. One population is those men with prostate cancer who are going to have surgery to have their prostate removed, who are undergoing prostatectomy. And then the other population is those men and women who have bladder cancer that has progressed to the point where we need to take out the whole bladder and undergo an operation called a cystectomy. And our motivation for each of those two groups were actually a little bit different. For those patients undergoing cystectomy, which is a big operation and really difficult to recover from, the main driver was the hypothesis that if I could literally talk to every patient every day after recovery, that they would have a smoother recovery because we would catch things earlier. And not only that they would have a smoother recovery, but they would have a less anxiety-filled recovery because they would get constant reassurance that, okay, this is normal, okay, not to worry about, oh, okay, this could be a sign of something bad later on, let's nip it in the bud right now. And the impetus for adopting SeamlessMD for that group was to find a way to do that where we could actually have significantly more communication with the patient without overburdening the care team. Because from the care team perspective, it's not realistic to be able to talk to every patient or to see every patient every day. And what the providers often feel is that, I keep saying the same things to these patients. They always call with this issue and it's such a simple, easy solution. And yet for each patient, that's the first time they're having that operation. That's the first time that they are 3 days out from surgery or 4 days out from surgery or 6 days out from surgery. So they have this urgency of, is this something I should worry about or not? And the providers feel like, oh my gosh, I can't keep up with this. So having a digital platform that would allow us to take all of this knowledge that we have that we wish the patient could automatically get and makes it feasible to actually automatically send it to them. And the beauty, the promise of the digital platform is that you can send it in a way that doesn't overload the patients. Most of the high volume centers around the country that do a lot of this operation, a lot of cystectomy, we will typically give them a booklet or a bunch of pamphlets so that they can prepare for their surgery. And I imagine what happens with those things is the patients with the best of intentions take that stuff home, and it goes on the kitchen table where all the mail and everything else that you need to get to is piled up, and it never actually gets processed and digested by the patient. But with the digital platform, 1 month before surgery, they can get a message saying, hey, now you should start doing this. And then 5 days before surgery, hey, you should start doing that. Just things in a more digestible, just-in-time format. That was the cystectomy patients. For those patients that wanted to have that are having their prostates removed, it's actually a more straightforward operation. They tend to be younger than the bladder cancer population, and they don't actually have as many issues with complications post-recovery. Not that it doesn't happen, but it's not as problematic. And what we want there is we wanted a seamless way to collect data from them, specifically patient-reported outcomes. Because if we wait till that one appointment a month after surgery or 2 months after surgery and say, how have you been doing? We know there's very good literature that says the answer you get is going to be based on how they happen to be doing that day. So if they've been having tons and tons of incontinence the whole first month and then have been doing better that day, they're going to say, oh yeah, I'm doing okay. Actually, incontinence is getting better. And we'll miss the opportunity to learn about the fact that they're suffering with this particular issue. So for prostates, it was more to collect data, patient-reported data, that we can use to learn about what can we do better for these people. For cystectomy, it was more to have more hands-on care for the patients in a manner that allowed the care team to actually be more hands-off.
And I guess, Jay, I mean, in terms of cystectomy, I know one of the key goals is around how do we, use this platform to monitor patients to prevent readmissions, which are, more common in the cystectomy population.
Mm-hmm.
How do you go about, I guess, making that fit within the clinical team workflow? Like, how did you decide who would be responsible for that sort of monitoring, and how did you make that work?
Yeah, I'd say that's still something that we need to perfect. Almost every single ERAS initiative that has ever been done for bladder cancer patients, for cystectomies, has shown things like decreased length of stay, faster walking, faster return of bowel function, less pain, etc. No one has consistently showed that you can actually get the readmission rate down dramatically. We actually have a program right now, we have a project that we're doing where Dr. Skinner, who's our chair of our department, is leading a team specifically looking exactly at what you just mentioned, Josh. What are the things that we can do to decrease readmissions? Because we know that readmissions, A, cost a ton more, and B, from a patient morale standpoint, are just complete destroyers of patient morale. Because when they have to go back to the hospital, it really makes them feel like, wait, why did I do this? Why did I go through this, etc. So one of the big things we're hoping is that with SeamlessMD, we're going to be able to decrease that along with other interventions, to be able to decrease that readmission rate. And we struggled, I'll be honest, we struggled with trying to figure out, how do you figure out who monitors this stuff? Who do these messages go to? And it might be simpler at a smaller program where you only have a small volume of these patients, or only one team, one care team who takes care of these patients. But at programs like Stanford and other big programs that do a lot of bladder cancer surgery, you have multiple different people involved. And it is important that you have a smooth, efficient process for being able to monitor those results. And one of the things that we're hoping for is that integrating it as much into the normal workflow as possible will make that easier. Digital platforms are great unless you have 8 of them to check, in which case you don't know what, I have to check this and then check that and then check that. So that can get tricky, and that's the thing to coordinate.
I think it's a really great point, Jay. I think oftentimes when people are more outsiders, technologists, trying to look on the inside, it's so easy to think, oh, tech solves everything. But then when you actually step into the clinical environment, you start to learn how complex of a microsystem it is in healthcare. Mm-hmm. And fitting into that clinical workflow is so critical for, frankly, whether it's a technology solution or not. You have to fit the clinical workflow to be relevant. That makes a ton of sense. And I appreciate you pointing that out. It's not a magic pill. Technology can only do so much, but I think, as Al and I have learned, and our team has learned, the implementation of that and fitting the clinician workflow is so critical. You talked earlier about the importance of patient-reported outcomes. I know one of the things that you're collecting with us is the Epic 26. I know that most organizations, I guess, are collecting patient-reported outcomes more from let's just collect the data, right? And so a lot of that's getting better. But how do you think about the future of, how do we actually make that data useful from a population point of view long term?
I think one of the things, I think there's two uses of those data. I think one, like you alluded, you want to collect as much as you can so that you can go back later and ask questions and say, hey, when we do this, if I use this kind of suture versus that kind of suture, is there a difference in the rate at which the patient's continence returns? Let me look through all these data that we've gotten from the last 1,000 patients to see if I can identify a difference. The other way I think that we can use those data, and this is the part where I think the digital availability can actually be helpful, is to empower the patients in their own recovery. Very often after surgery, we're usually asking patients to do things like doing Kegel exercises to try to improve their continence after surgery, or walking and doing breathing exercises after cystectomy so that they don't have as many complications. So if patients could see their recovery, if they could track it, I think it would make them feel much more invested. And I think one of the things that I've learned over the years for patients undergoing cancer surgery, one of the hardest things is the uncertainty of what's going to happen to me and the loss of control over being able to impact that. So if they could see where they are on their trajectory toward full recovery and have a list of things that they can do, or a couple of things that they can do, I think being able to see progress toward a goal, just like any of us with any project, will help patients feel so much more engaged in their own recovery.
It's a great point. It kind of reminds me how, when we talk to folks more, let's say in orthopedics, when we're in the clinical world, we look at things like complication rates and length of stay and all that. But if you were to ask a 70-year-old grandmother, what's her goal with the knee replacement surgery, it would be, well, I want to walk my daughter down the aisle at her wedding this year or something like that. And we don't often think of that from a clinical point of view. So I think you're right. I think bringing the patient voice to the forefront is really, really powerful and important. I think one of the things Al and I are always interested in is the challenge, to your point, around leadership and change management. And so, whether it's, bringing something like a digital patient engagement platform or bringing ERAS or Prehabilitation to a department, unfortunately, you can't just do it on your own, right? You actually have to have a team working together. When you're bringing like something like that in, like, how do you think about getting that change management, getting that buy-in? Like what tips would you have for a clinician who's kind of new to that sort of leadership change management process?
Yeah, I think so many of us make the critical mistake of, I've got the solution, and let me just enlighten these poor, unenlightened souls, and they will see me as the savior and everything's going to be great. And I think we so quickly realize that does not work at all. I think the best bet is actually to spend time listening and talking to the group, whatever group it is that you're working with, that you're trying to bring about this change in, and just create a sense of urgency. Don't focus on your vision. Just get agreement that this is a problem. If that's all you can do, that's a great start. Because until people agree that there is some sense of urgency around whatever the issue is, they're not going to follow your vision. Especially if you're an outsider, you're going to get that classic, it doesn't work that way here. You don't understand, you don't understand so insert your institution's name here, way. Like that, those things don't work here. But spending time and saying, so Dr. Smith, I see we do 100 to 200 cystectomies a year, and I was looking through data, our readmission rate is et cetera, or our length of stay is this. What are your thoughts on that? What do you think is causing this, et cetera? Just getting people to realize that this is not tenable, that we're not taking, in this particular case for cystectomy patients, we're not taking the best care of patients possible. And then from there, once you have a coalition who has that sense of urgency with you, then saying, okay, well, here's a vision of how it could be. Would this be better? Or how would this be? If we could take a 60% complication rate and a 33% readmission rate, and what if instead we could lower the length of stay by 3 days, lower our cost by about $15,000 per patient, reduce the complication rate by half, and maybe even impact our readmission rate by 10%, 20%. Would that be meaningful? And I think then you start having a conversation. But it's important. I think it's really important to realize that every institution is different and every group is different. And you kind of have to tailor whatever you're going to do to that particular environment. Trying just to jam your solution into every different institution, most places you're going to run into more headwinds than tailwinds if you try that.
Jay, I think there's such a powerful insight there. What really resonated with me is when you said, forget the solution for a second, focus on, can we get alignment on what the problem is, or if there's even a problem? Because if there isn't alignment there's no solution to anything. It's not even relevant. And it reminds me, even in our organization, right, Alan, where, instead of pitching solutions, it's more important to actually, like, let's say, show the data, even convince someone there's a problem. If they don't agree with you, I mean, the rest doesn't really matter. So I really love that. And that makes a lot of sense. Before we talk about ERAS, talk about, do we actually have a length of stay issue, a patient experience issue, a quality issue? If not, the rest doesn't matter. I absolutely love that. Maybe just to shift gears a little bit, at the start of the pandemic, I remember, like, your team was at the Society of Urologic Oncology conference, and you shared some of the work that your team has done with Seamless. But wondering, now that we're getting closer to past the pandemic and California is opening up, and you mentioned earlier, you're probably doing more video visits than you did pre-COVID and doing more digital now. But once things are, let's call it, back to more face-to-face post-pandemic, what things do you think will stay virtual in care delivery, and what things do you think will go back face-to-face?
Yeah, I think this is the conversation that every hospital, every chief medical officer and chief medical informatics officer needs to be having right now, in that we have all had this intense desire for the last 15 months, 16 months for things to just go back to normal. We've missed our world. We haven't been shaking hands. We haven't been hugging. We haven't been having happy hours. So we have this intense desire to go back to all of that. And I fully believe that we will go back to all of that. I think our task as leaders in healthcare is to figure out, okay, what were the good things that came out of the pandemic? Because of course the deaths and the economic crippling and all that were horrific. But as with every other crisis, there are some little pearls and nuggets that you can take with you even after. And I fully believe that doing care virtually when it's feasible should continue forever. I have so many patients, both here and when I was at MD Anderson, I had so many patients that travel 3, 4, and 5 hours to see me, where, if I'm being completely honest with you guys, I don't even lay a hand on them in terms of a stethoscope or doing any sort of physical exam. I'm there to review their CT scan with them, or I'm there to go over their labs. We're following up, et cetera. Or they're there to sign consent for the surgery that I'll be doing in 3 weeks, et cetera. And it makes no sense to me to have a patient drive all that way, pay for parking, run late, be stressed out, stress me out because they're late, and do all that when they could easily be sitting in their own home and we can have the same conversation. And a 15-minute appointment only takes 15 minutes, as opposed to that whole 3-hour drive and a 3-hour drive back, and paying for the hotel room the night before if they need to, or getting a dog sitter, or all those other little things. Like you said, Josh, we don't think about all the little things that go into a patient's perception of what an encounter is. We just want to get Miss Smith to have range of motion of 85 degrees, but all she cares about is walking her daughter down the aisle or being there for her granddaughter's graduation, let's say. So similar to that, in the ambulatory space, we think it's, oh, you know what, let's just see you back in 2 weeks. Let's just see you back. But that represents a big deal for the patient. Their son's got to take a day off from work. Someone's got to make a lot of sacrifices to make that happen. All those things we should get rid of, and we should just keep that visit virtual. That said, I think there is so much to be gained from a direct, in-person, face-to-face encounter. I think there's something about a hug, about a handshake, about putting your hand on someone's shoulder or their thigh when they're crying, when you've just given them horrible news, or if they're crying for joy because you just told them that they're cured and cancer-free. I think there's some things that we want to preserve, but we have to be thoughtful in each individual case. Do I want to make this patient drive 4 hours just so I can put my hand on their shoulder and say, hey, you're cancer-free? Or would they appreciate hearing that surrounded by their grandkids sitting on their couch? And that's where the work, I think, will come in for leaders in healthcare.
And certainly virtual care has made the world smaller, and maybe in the past most patients would want to focus more on providers who are local to them, where they can kind of go in person. But I'm curious, I mean, maybe the pandemic period is not the best example or time to look at this, but I'm wondering if you've seen more patients who've joined your practice from, let's say, further away cities or states because they can do more virtual care with you. Like, are there more patients coming in from further states? Yeah, they have to come to Stanford to get the surgery done, but knowing that pre and post care can happen anywhere in the country, are you seeing that more now, or is that still TBD?
Yeah, no, we are actually seeing a bit more of that. For patients who it would have been too inconvenient to bother coming, now, like you said, it's just a video visit, so it's easier for them to come. And I actually think on a larger scale, we should take advantage of this, and we should get rid of, well, I should be careful, this might be controversial, but we should rethink the concept of state medical boards. It doesn't make any sense that if I get in trouble with the California State Medical Board and can't practice, I go to Oklahoma or I go to Maine and just start over. We've all heard the Dr. Death podcast where people kind of just keep repeating the same patterns of behavior just in different medical boards. I think we all speak the same language. We are all one country. I think it's time we consider a national federated medical board, just because the idea of catchment areas is so crazy to me. Having your hip replaced in New York costs wildly different than having your hip replaced in Arkansas versus other parts of the country. I think these regional differences could be dissolved if we made it easier for patients to just find the best care. And the other advantage of that is that people who are, let's say, in the middle of a very rural area where they don't have access to a bladder cancer specialist aren't just rolling the dice and hoping that the person that they have to see is good or not. They can actually see one of the few people around the country, one of my colleagues who's an expert in bladder cancer care. And that would allow people to become further specialized and really good. I've seen, I don't know how many hundreds, maybe thousands of bladder cancer patients, but I know if I'd seen double that amount by now, I would probably be twice as far along in my thinking. So we can take that expertise that you get and really make it into a virtuous cycle where, since you do so much bladder cancer care, you can get really good and thoughtful and figure out how best to take care of these patients. And other people don't have to do it once or twice a year and try to, do an okay job of it.
Actually, Jay, I'm kind of curious in terms of, because the more specialized you get, then you get really good at that craft, but then maybe you arguably see, let's call it, less variety of urology care versus those who are more generalists in the community. They don't get the volume to be, let's say, to do like cystectomies as well as you can, but they get the variety of just being able to do and see everything. Where do you sit on that now? Like, I mean, looking back, do you miss any aspect of more community broad care, or you're just a master of your craft and you love it now?
Both, honestly, both. I do essentially one thing. I do bladder cancer surgeries. I mean, I do bladder cancer care, but I don't even do prostate surgery that often anymore. I don't even do kidney surgery. Even though I'm board certified to do all urologic oncology, I have chosen to focus and drill down really deep on one thing, because I don't want to not know what the best thing is. When someone comes into my office with bladder cancer, I have a sense for what the best treatment would be for this patient. Honestly, if they come in with something else, I would have to go and read and say, well, what are the most recent guidelines? Let me go look that up. And whenever you do that, there's a chance that you may misinterpret a guideline or you may not offer the best thing. So yeah, it's fun. Early on, I was doing all cancers in urology. So I was doing kidney cancer, prostate cancer, testis cancer, penile cancer. And it's nice to have that variety. But I think if you truly want to make a deep impact, it's best if you pick one thing and try to really think deeply about it. I think all of us, when we go to school, they teach us math and they teach us home ec and they teach you everything. And as we go further and further in life, you sort of hone down to a narrower area. And I think there's a useful reason for that. But I don't.
Sorry, go ahead, Jay.
I don't fault my colleagues who either choose to stay broad or they're in the kind of practice where they don't see enough of just that one thing to make a whole career out of. So what I'm talking about is honestly a luxury in medicine, in that you can be at a place that's high volume enough to work on just one thing. I would say for most urologists and most even academic urologists, that's not feasible to be busy enough.
That's fair. I'll tell you a funny story. So I heard about this story where there was a large hospital with a VIP patient whose name was on the hospital. So big donor. And he came in with acute cholecystitis, needed gallbladder surgery, and demanded, the head of the surgical program to do the surgery. Now, the head of the surgical program is, a surgical oncology specialist, probably hadn't done a gallbladder in who knows how many years. And then was basically, I won't say pressured, but was obligated to do this gallbladder surgery. Brought in his fellow, brought in a whole team. It went well. It was fine. But it was funny because, that patient thinks that the head of the surgical program would be the best surgeon, when in fact, given that he does no gallbladder surgery anymore, probably wasn't the best person to do that case. So it just reminds me of that, but that volume comes specialization and all that. Jay, maybe one last question before we go into the fast five, if that's okay. I know Al and I were always interested in kind of value-based care changes. We're hearing a lot about value-based care for, like orthopedics and cardiac care. Wondering how much of that you're seeing lately in urology and if that's impacted how your program works lately.
Yeah, I think we're going to hear more and more and more about value-based care. And I actually think it is the right way to go. I think the current system in the US with healthcare is not tenable. I don't think we can keep doing this forever. We have a rapidly aging population that just needs more and more and more medical services. Those services just keep getting more and more expensive. And we have a finite pool of resources that we can apply to that. So I think we have to become mindful about, well, what does everything cost? Not just that money or cost is the bottom line, but relative to the outcomes, what does everything cost? If you can make things a lot better, but it bankrupts the entire system and there's no more resource left for any other patient, we'd say, well, that doesn't make sense. We can't do that, And you have to find a way to integrate value-based thinking into everything we do. So at Stanford, that's something that we have a whole program, not just in urology, but at the institutional level in value-based care, because we see that things are getting too expensive. And there are so many small things that we can do to minimize over-ordering of unnecessary expensive tests, of getting an answer without sending someone to a specialist in a simple way. And, this is similar to what we were talking about. This is where we're at the point where I think what we need to do is create the urgency around this and let the solutions bubble up in a granular way so that they actually have a chance of taking root at each institution. And that's where we are at Stanford. I won't lie to you and say that we've figured it out, but we are very much focused on exactly that. So each department has what's called the value-based champion, because if you have the hospital CEO send a memo saying, hey, you all are too expensive, everybody's going to cut out 20% of your expenses, or you can't do this kind of hip surgery, or you can't do that, people will go up in arms saying, what do you know about what we do? Whereas if you empower each department to think about, well, what are the things in our environment where we could be better stewards of these resources, it's much more likely to fit into the workflows and it's going to be much easier to implement that change because it's coming from within as opposed to being imposed from up on high.
I love that. It's much more effective to provide clear direction or maybe goals for the organization than let the individual teams, figure out the best way to achieve that goal instead of kind of being, authoritative about, do this in urology. It's like, no, like give us a direction and we know best at the front line how to figure it out. Makes a lot of sense.
And it's also a great way to grow local leaders because you can see how each group is doing it and say, hey, we noticed you did this really well in ophthalmology. Can you share with us and sort of have that person get more visibility and sort of use their learning at the institutional level to benefit more than just that one group.
Mm-hmm.
I love that.
Yeah, that's fantastic. And I think just that it's really valuable just hearing value-based thinking. I think that's a valuable insight that more individuals need to have. And maybe, Stanford is one of the lucky places that's empowering folks to do that. So that's really awesome insight there. At this point, we are going to jump over to what we call the Fast Five, Jay. So it's essentially just, 5 questions that will kind of rapid fire at you, but you can answer it as quickly or succinctly as you'd like.
All right.
So the first question,
Family Feud at that last part where
exactly
you come up behind me.
Yeah, Jay, you have to pick the right answer.
We'll flash it behind us. If it's wrong, you're out. So it's good. So first question we have is, what is your favorite book or book you've gifted the most?
The book that I have gifted the most is a book that's called Crucial Conversations. I don't know if either of you have heard of it. Yeah. It's by 4 authors. I don't remember their 4 names, but you can just Google it. It's about how to have conversations about things that are really difficult to talk about. We've all been in those kinds of discussions where you can feel your heart rate go up and you're sort of, racing and your throat's dry. And sometimes we or the other person will say things we don't mean and it's very heated and you walk away, oh my God, what just happened? And you need to sort of sit down at your desk or call somebody and say, I got to tell you about what just happened. This book is really great. I've read it 4 times and I've probably sent about 15 copies to friends and colleagues around the country, where it sort of just helps you think through and allows you in that moment to just not get triggered and to just say, wait, hold on. I feel myself getting upset and I don't want to do that. This is important enough for me to talk about, or this is important for us to get right. Let's make sure we do this right. If you're looking for a read, I will send it to you, in fact, if you give me your address. It is a fantastic, it's not a story. There's no Fabio type guy on the cover. It's a self-help type book. But like I said, I've read it 4 times. If you look at my copy, it's underlined and highlighted and there's little notes in the margins are super tiny, but there's notes in there and stuff. I love it.
Awesome.
It's funny. I think a lot of people, myself included, don't reread books enough. That we get fixated on like the next book, but probably the best books should be the ones that you keep rereading so that you can like really make it part of you.
Yeah. How often have you finished a book and said, oh my gosh, this was amazing. And then you put it on your shelf and life gets you away and you don't actually get to do anything it said.
Yeah, I'm also a big believer now in, I don't know if you've ever listened to like Naval Ravikant's stuff, Jay. He's like this like investor. Yeah, sounds like you have.
Yeah. He's such a deep thinker. One of my friends is good friends with him. So I think I follow him on Instagram and see his posts and stuff. And I've read a couple of things by him.
Yeah. So basically now we're 2 degrees away from Naval Ravikant. We know you, right, Jay? but he says one of these things where he often starts books and doesn't finish them. And he says, that should be okay. Not every book is full of gems throughout the entire book. You should be willing to drop books or read 10 at the same time and pick what you like and leave what you don't like. So
yeah, fully agree with him on that.
Really
There's no grade, so we don't have to finish a book. If you don't like it,
there's no test.
That's great. All right. Question 2 that we have: how has an apparent failure set you up for greater success?
Which one? Honestly, the one that I would choose to talk about here, without getting to specifics, is something I alluded to earlier, where when I first got to Stanford, I had been at MD Anderson for 10 years. I was there as a fellow, and then I stayed on as faculty, and I had grown and risen there to become the center medical director of the whole GU center. And I knew that at MD Anderson, I had a lot of trust that people had in me. And it was actually relatively easier to get things done. It was easy because I would just say, hey guys, we should try this. And it would happen. And then when I started at Stanford, I said, okay, I'm being brought in as this hotshot guy from MD Anderson, and I'm going to make everything better. And I came in and I didn't take my advice, Josh, about creating urgency first. I just went about trying to explain my vision and wanted to just impart all this wisdom that I thought I had. And I realized that I was actually not being effective. That people who, in a different context, would have wanted the same things to happen were actually resisting. And I learned that that was because of the way I was going about doing it. And that was really humbling for me. Honestly, it was humbling, and it was really good for me to have those early failures, because it made me pause and it made me rethink, wait, what am I doing? Why isn't this working? What's the reason? Because these people are good people. They say they want these things, and yet when it comes to doing them, they're not doing them. Is it because they don't like me? Is it because they don't really want them? Or is it something else? And that forced me, honestly, just to swallow a whole lot of my own ego and just realize that I don't have all the answers. And the idea as a leader is not to come in and have all the answers. You don't need to be the smartest, fastest, strongest, anything as a leader. The true sign of a leader is someone that can empower their people to do all their best work. Can you get all of these people to do their best work? Not can you get them to be in awe of your greatness? Because no one person actually has really true greatness. The way we're great is in what we can bring out in others.
Oh, that's awesome. Question 3 is a bit different. Would you rather have super strength, super speed, or the ability to read people's minds?
Super strength, super speed, or the ability to reach. I think I would, of those 3, I would choose to read people's minds. Because I think if all you have is super strength and if all you have is super speed, the world is still dependent on you. But if you can read other people's minds, just to tie into what I just said, you can be so much more effective in speaking their language and getting other people to rise to their greatest potential.
But Jay, follow-up question. What if I told you you could read everyone's mind, but you couldn't turn it off? So everywhere you went, you were hearing everything. Would you still take it?
Yeah, that clearly gets to be a little bit trickier. I think I would box myself and only selectively let myself out of a room.
Right.
Yeah, that could quickly turn into its own form of torture. Yes.
Yeah, it sounds like a way. That's funny.
Twilight Zone episode. That's great. Question 4, what is something in healthcare you believe that others might find insane?
Well, what we were talking about earlier, the fact that we do medicine in exactly the same way that our grandparents did medicine. And my grandparents grew up in India, and we still practice medicine essentially the same way that they did back then. I think that is absolutely crazy.
Yeah, I would agree there.
Jay, kind of follow up for you. I mean, I think one of the things that I've noticed, even in myself, right, which is as you grow up, at a certain point, kind of your values, your principles are hard to change. I think for a lot of people, once you hit maybe your 20s or 30s, like your values are pretty much set in stone. It's hard to change them. I'm wondering, do you see that in medicine a lot, where part of it is, yeah, you know what, like these are my values as a clinician, when I trained, and it's really hard to change that.
I don't think that any of us ever gets completely closed off to being influenced. I think, yeah, we are, for the most part, fairly maturely formed by our mid-20s or so. Our brains are not as plastic as they were younger, but I think we are all very much open to new experiences and new thoughts. And I think that's actually one of the best things about practicing change management and leadership, getting people who are very opposed to you about something and talking and really listening to them and understanding their perspective. And then once you understand each other, trying to find the common middle ground where you both sort of are forming new synapses and doing things differently. I think it's never too late for that. I think politically, medically, spiritually, socially, philosophically, I think we are all plastic till the day we die.
I also believe like thinking like that probably makes you happier than some other people. You know, knowing that and believing that you can change, that you can be more open-minded, that you can be happier.
Yeah. Yes, I agree with that. I agree with that completely.
Mhm. All right, last question that we have, Jay, and this is a pandemic-related question. What is one hobby or activity that you picked up during the pandemic?
Ooh, I picked up a couple of them. I got on a sourdough bandwagon.
Okay.
Very late though, very late. I would say maybe maybe 6 months into the pandemic, I started making sourdough bread,
Okay.
and I have an active starter in my
Right.
fridge right now. I make bagels and bread and stuff every week or two.
Cool.
But I also realize that the world's going to open back up, and we all have to lose the weight. So I need
Right.
to let the starter hibernate a bit more often than I do right now.
Yeah. You can switch to a kombucha starter. Start brewing your own kombucha.
Kombucha is incredibly difficult to brew. I was doing
Apparently,
kefir
yeah.
for a while,
Okay.
and that's a little bit easier, but that's also got its own issues.
Yeah. Oh wow.
And
That's
Jay,
awesome.
for our audience, where can they buy your sourdough bread? Are you selling it anywhere?
Oh yeah. Message me. Send me a DM. Is that what the kids call it? DM me. Yeah. Hashtag buy sourdough. I don't know. I'm not sure I have a commercial license, but I will brag for a second. I am a pretty badass cook, and a baker. So
Yeah.
if I offer you some bread, try it. You might enjoy it.
You heard it here first.
That's awesome. Well, Jay, we'll wrap it up there, but do want to thank you so much for being on the show today, imparting a ton of wisdom for our audience. There was definitely a lot of nuggets in there that I'm going to take on in the rest of my life, and a lot of influence in terms of leadership and how to be an effective communicator when looking at problems and looking at solutions. So that's really valuable, really great insights. But I'll end it there for you. But thanks so much for being on the show today.
Thank you, Jay.
Yeah, this was a blast. Thank you guys so much for having me. I enjoyed talking to you. Thank you for all that you do on behalf of all of our patients. And thanks for trying to share and sort of grow the conversation around these important topics. I appreciate you both.
Thank you, Jay.
Likewise.
Appreciate that.
All right. Take care.